resistant hypertension. Please, Dr. Ehab. Please.
Thank you, Mr. Chairman, Dr. Said. First of all, I want to thank Dr. Said, Dr. Amgad, for inviting me and all the organizing committee, and it's a great pleasure to be here in this beautiful kingdom of Bahrain. In fact, I didn't put an outline for the lecture because we'll try to talk about everything concerning the resistant hypertension. Hypertension, as we heard a few minutes ago, is a big problem. So when we go to these maps in front of you, we'll find that the incidence of hypertension 2019 in Kingdom of Bahrain was about 15% in males and females, while in Egypt it was a little bit higher in the range of 25%. In the scanning done in Egypt since over the last 2 years, they scanned 50 million patients aging 18 years and above, and the actual incidence of hypertension was about 20%. The problem with the hypertension, it's not a solitary disease, and that's why when we talk about the mild hypertension, it's not common to find a patient with a mild hypertension, blood pressure of 145/92 or 93 or something like this. Usually you find a moderate or severe hypertension, stage 2, stage 3. The other problem is that hypertension is not usually solitary disease. It's usually combined diabetes, ischemic heart disease, coronary artery disease, kidney disease, dyslipidemia, or many diseases may group together. As we heard before, the hypertension, many of the patients with hypertension are not controlled. In fact, they are treated. There are people who are not treated at all. Many people who are treated are not controlled. And from these people, patients with resistant hypertension, it's estimated to be about 17.4%, as we see on the slide. The problem with uncontrolled of blood pressure, because we have to differentiate between uncontrolled blood pressure and resistant hypertension. It's some factors related to the patients. And this is very common. Economic factor, the medicine is too expensive for the patient to buy it. He will get it once, as you prescribed, but he will not get it again, except he's covered with something, an insurance company, or somebody who's paying for him. The second point is the side effects. Patients tell each other, they know the side effects. Many patients go to the internet, they see the insert leaflet of the medicine, and they know the side effects, and it's very common with beta blockers in males, and we know that. The second is the physician inertia, as we heard minutes ago. And the third is the other factor like smoking, concomitant medications, and as we said, the complex medications. I'll go back to the story of Franklin Roosevelt. Franklin Roosevelt, he died, as we hear now, in 1945. And in fact, I'm not interested with this. I'll tell you what his physician said. Admiral Ross, he was his physician. He wrote down in the newspaper, there was no indication of imminent danger. And this is his blood pressure chart. His blood pressure started long before his death with a systolic blood pressure over 200. Anyhow, let's go to the resistant hypertension. Resistant hypertension, by definition, and the definition is important because it's the use of 3 medications in the optimum dose for optimum time. Why I'm saying optimum time? Because a drug like ACE inhibitor or ARBs, they take some time to act in the full strength. So we have to give a full dose of 3 medications for optimum time. One of them is the diuretic, and the blood pressure is not going down. Or a patient who is controlled with 4 medications of different classes. In this diagram, we'll classify the patients with hypertension, controlled, uncontrolled. In the uncontrolled, we have the resistant hypertension, subclassified into 3 groups: resistant hypertension, pseudo-resistant hypertension, and the patients who are controlled with 4 medications. In fact, when we talk about the pseudo-resistant hypertension, we are talking about the white coat syndrome, the poor adherence, and the great mistake of poor measurement of blood pressure and lack of treatment. All of this will come to you. When they come to you, you measure the blood pressure, you prescribed already the medications, blood pressure is still high. Patient may not taking the medicine properly. Patients cannot afford the medicine. He's measuring the blood pressure in not an accurate way, and we'll explain that immediately. Many factors play or take an act in the resistant hypertension: endothelial dysfunction, elevated aldosterone level, hypervolemia, insulin resistance, genetic factor, and sympathetic hypertones. So when we want to put a patient under the category of resistant hypertension, you have to make sure of that the patient taking the 3 medication, as we said, and the patient is taking, and to exclude the pseudo-resistance, the patient is not using drugs, he's as possible decreasing smoking and no alcohol use. There is no herbal supplements, which is very common now. The people tells you, especially the ladies, I'm getting a herbal supplement to reduce my weight. We'll discuss that in a minute. Or to exclude pseudo-resistance, as we said, and investigate the patient. So to go in a map for that, we'll find, and first of all, is the office-resistant hypertension a consideration? If it's yes, because at the diagram we saw before, the patient may be sitting outside waiting for you for 2 hours, and she's very angry, anxious. She comes in, you measure the blood pressure, it's high. And then she tells you the next visit, doctor, when I left, after leaving your office, I went down, I went to a pharmacy, I got my blood pressure checked, and it's only 130/85. In your office, it was 180/90 or 95 or something. So we go to the ambulatory blood pressure evaluations or home readings. Okay, if that is yes. If the patient is interfering substance, taking something else like sympathomimetics, herbal supplements, non-steroidal, all the ladies, arthritis, all of them taking a non-steroidal anti-inflammatory. She has an asthma and she's taking corticosteroids, maybe. If the patient is obese or there is a diagnosis of metabolic syndrome, can we order the patient to do an anaerobic exercise and reduce weight? That would be great. If there are any causes of secondary hypertension, we'll see in a minute. The most important item is the measurement of blood pressure. The measurement of blood pressure, it depends on the cuff. If you go to any clinic, most of them, to be accurate, will find that there is one machine with one cuff, and this cuff is used for everybody. The obese lady, the thin ladies, anybody. And of course, we know that the small cuff will cause overestimation of the blood pressure, while the large cuff will underestimate the blood pressure. The rules of measuring a right blood pressure, we just heard it minutes ago, so we'll skip it. You are not the patient with hypertension, or he comes to you saying, I have a high blood pressure, and you start to put your thinking towards the patients being a resistant hypertensive patients. You have to examine the patient for causes of secondary hypertension. Is he a malar flush and a systemic lupus something? Is he a Cushing disease? Steroids using? He has an renal artery stenosis. Sometimes you can just diagnose it by putting the cystoscope on the abdomen. He's have a beroe on the back, and he has a coarctation. Do you feel his radial and femoral pulses, and you estimate if there is any incidence of coarctation or not? Many patients, they have suprarenal masses, and this mass, and very common, Crohn's disease is not in rare as we believe. Crohn's disease is common, and from time to time we find that. Pheochromocytoma is also possible and diagnosed from time to time. Abdominal swelling, polycystic kidney, Williams tumor, neoplasm, and they cause elevation of blood pressure. I'll tell you in a second a very nice story for somebody whom I know. That guy, he was a 32 years old man, no problem, just a smoker, and he kept complaining of fever. So at the time of COVID, any fever is considered as a COVID to start with. But during the investigation, they noticed that his liver enzymes are high. And it was diagnosed as hepatitis. And the bilirubin was found to be elevated, and he was diagnosed as hepatitis. He went to the hepatologist, and he told him, okay, we'll do an abdominal ultrasound. On doing the abdominal ultrasound, they discovered that he has a renal tumor, a kidney tumor, and an operation was done, and the tumor was excised. Accidentally, but it happens from time to time. The most common cause from my concept is the medications. Contraceptive pills, hormonal therapy, yes. Diet pills, as we said, it's very common. It's very common cause, can be. Nasal decongestant. Patients are keeping the sprayer of nasal decongestant in their pockets. They are using it all the time, and they don't know that that may increase their blood pressure. Stimulant drugs like amphetamine, cocaine, and other stuff. Licorice, Ramadan is coming. كل عام وأنتم بخير. And the people are enjoying drinking licorice, but it increases the blood pressure, so we have to teach and warn our patients. Other anti-cancer medications, anabolic steroids, the guys who are playing at the gym and taking anabolic steroid and non-steroidal anti-inflammatory for all the ladies, it's important because they also increase the blood pressure. The use of ambulatory blood pressure in the diagnosis of resistant hypertension is important. It diagnoses white coat syndrome, masked hypertension, episodic hypertension, autonomic dysfunction, and nocturnal blood pressure dipping. However, when we come to the home blood pressure, because you cannot do ambulatory blood pressure every now and then or every week and so on, you depend mainly on the home blood pressure measurement. And this is the trick. Home blood pressure measurement, you find the lady or the patients coming to you the second visit, and she has a paper in her hand. On this paper, she's writing the readings, or she's writing the measurements of blood pressure she made at home, or her husband or her son did it to her. The point is, you have to make sure of a few things. Is her blood pressure machine is accurate? She can measure the blood pressure properly? She can use that machine? And when is she measuring the blood pressure? Because what happens, and even to us, you only remember to measure your blood pressure when you have headache, when you are tired, when you are angry, you have a fight, whatever. So just ask the patient. What I do, frankly, clinically, I bring the patient, I told her or ask her to bring her blood pressure machine and to measure her blood pressure in the clinic in front of me. I don't measure it. She measures the blood pressure. And you make sure that she's doing the right technique. So the home blood pressure measurements, we have intermittent, it's easy, it's an easy way. It helps in the diagnosis of intermittent elevation of blood pressure, white coat syndrome, masked hypertension, for follow-up during medications, and the testing the patient machine and evaluation is also important. Of course, the investigations we use, it's the EKG, transthoracic echo, complete blood count, aldosterone, renin, may be expensive, but sometimes you need to do it. Thyroid stimulating hormone, renal echo, and renal arterial duplex. If you hit the target, you can go down from 3 or 4 medications into just 1 or 2 medications. In conclusion, the roadmap for management of resistant hypertension is number 1, confirm resistant hypertension. Number 2, exclude pseudo-resistance, multi-reversible lifestyle factors, modify reversible lifestyle factors, eliminate as possible the drug interaction. And in fact, this is important. You have somebody coming to you, and she have knee pain, and she's taking non-steroidal. You tell her, see, lady, I'm sorry, but you cannot use this non-steroidal anti-inflammatory because it increases your blood pressure. This is not logic. Maybe she's not feeling that her blood pressure is high, but she wants to move. So you have to make a compromise. Screen for secondary hypertension, intensify the drug treatment. If no improvement, refer to a hypertension specialist. Thank you very much.
Thank you.